All right, everybody. This is Dr. Stone. This is Dr. Charina Ramirez from Children's Health. We'll go ahead and get going here. Thank you, everyone, for joining us. So as most of y'all know, this is our monthly Instagram Live question and answer session. So this all kind of started with me getting in front of the camera and just answering some Gen Peds questions for people out there in the community. And it's developed into this almost subspecialty spotlight once a month. So this has been really fun. I'll get into Dr. Ramirez's intro in a second, but she was actually my mentor in residency, so I have a personal connection there. So before we get started, I do want to throw out there, we do have a new YouTube channel. You can see that or find that on our Instagram profile. It has all the videos I've recorded since the inception of this monthly question and answer session. And if you subscribe to our page, then you'll get notified every time I put a new video up. As all of y'all know, this is not actual medical advice. This is mostly just for fun and just to get the insight of some physicians that into thought processes of pediatric pathologies and physiologies, and just to kind of get to know how we think about things. But if you ever have a concern for your child or yourself, please raise that concern with your child's doctor or your own doctor, and don't take our advice, because we are just two people in front of a screen on the internet. All right, we'll go ahead and get into tonight. So tonight our guest graduated medical school from UTMB in Galveston, followed by her pediatrics residency from Children's Health in Dallas. And finally, her pediatric gastroenterology, hepatology, and nutrition fellowship from UT Southwestern, also here in Dallas. She currently serves as an associate professor in the Department of Pediatrics, Division of Gastroenterology, Hepatology, and Nutrition, and as an Associate Fellowship Director at UT Southwestern Children's Health. Her professional interest is pediatric liver disease. However, she treats a wide breadth of pediatric GI-related illnesses, including gastroesophageal reflux disease, constipation, celiac disease, eosinophilic esophagitis, malnutrition, fatty liver disease, inflammatory bowel disease, and irritable bowel syndrome. Lots of pathologies in the GI tract.
That's right.
So it is a privilege and honor to introduce Dr. Charina Ramirez.
Thank you. Thanks, Dr. Stone. And it's really great to be here with you this evening. And as you know, you're one of the top residents ever.
Don't listen to her.
That's why he's doing this. He's always top and still is.
Oh, thank you. So before we get started, if someone sees this video tonight and is interested in having their child see you, where can they find you practicing, and where are you seeing patients?
Yeah, so I see patients mainly in the Children's Health Dallas campus, but once a week I also go to the Children's Health Specialty Center in Park Cities, which is really inside the Margot Perot building on that first floor across the French Cafe.
Okay, and that's in the north part of Dallas, is that right? Where is that at?
Kind of in the heart of Dallas. It's
Okay.
off of Walnut Hill and 75.
Okay.
Yeah.
All right, so our patients who are living more towards Dallas, more towards the south side of Frisco and our geographic location may be very interested in seeing Dr. Charina Ramirez for your GI-related illnesses in your kiddos. All right, so we'll get started with our questions tonight. Let's start with the first one. And let's start with the most common pediatric GI complaint there is, constipation. So, what is your typical over-the-counter regimen for constipation based on age groups? Toddlers, school age, adolescents. Do most children outgrow their constipation?
Yeah, so this is really a great question. I think probably I would say a big part of my practice, even though I have some specialties like fatty liver disease and metabolic liver disease, GI complaints such as constipation is one of the highest reasons why I see my patients. First of all, when you look at over-the-counter constipation medicines, you want to figure out, well, what is it that's going on?
Sure.
I know a lot of people say, oh, it's just constipation. But when you have a toddler who's struggling or a baby who's really struggling and crying and trying to get that poop out, it's really distressful, especially as the mom or the dad or the parent. And you're just like, what do I do with this baby?
Yeah.
And so in trying to help out, one of the things that I brought here, and I brought some props.
Brought some toys for us to play with.
Yeah, so
All
okay.
right.
So one of the first things is, so when an infant has constipation, If juice doesn't work, so that's one of our first things is apple juice, prune juice, or pear juice. If that doesn't work, the next step really is if they're in dire need of really needing to poop, you can get this liquid glycerin suppository. Pediatric has many different types of medications, and so you have to read what's in the active ingredient.
You want me to hold that up to the camera real quick?
Yes, here you go.
All right, guys. So this is the first medication she's talking about. This is pediatric glycerin suppositories.
Okay.
All right.
All right, so I'm just gonna take this out so you all can see what's in here. There's 6 of them, but this is basically a glycerin suppository. It already has lube on the tip of it, and when you insert this into the baby's bottom, into their anus, you have to squeeze, but keep squeezing the bulb and then take it out. Don't let the bulb go inside while the tip is still inside because your infant will wail. I've personally done that to my own daughter.
Yeah, so
Not good.
if you let it go whenever it's still inside the kid, you're creating negative pressure to suck the mucosa of the intestine back into that, which is obviously very painful.
It can be very painful and they just wail.
Yeah.
And then they never want you to ever put this in their bottom.
Sure.
And sometimes it's helpful to just get immediate relief.
Yeah, absolutely.
And you don't have to worry about squeezing every little drop in. Just get it in there and then get it out.
Sure.
So that's really one that will provide immediate relief. Now, first, if you're like, well, my baby has constipation, but not that bad, but the apple juice didn't work. Yeah. Pediatric now has this newer line. It's called docosate sodium. So it's a liquid too. Yeah. And what's nice is docosate sodium is a really gentle laxative, and it's a softener.
Got it.
And then again,
real quick. This is the next medication she's talking about. All right.
Okay. Now for this one dose is 15 ml, which is 50 milligrams. So you could try starting with half of this if you have a baby, maybe go up to the full dose if you have an older infant. And it's really gentle, so you may not see immediate relief. You may have to give this 2 or 3 days before you see a good result. Okay. But everybody's body is different.
Yeah,
so
absolutely.
some babies may respond right away.
Yeah, definitely.
Okay. Now there's even more.
Okay, here we go.
So you have one that gives you immediate relief, but then another one that softens, and so softeners are going to be our most common ones. So Miralax is the one. Now sometimes people don't like using Miralax for all the bad press that it's received.
Miralax, I'm sure everyone out there has seen this.
Yes, and we had this in our household for a little while.
There you go.
And so the way you use this is you just pour it and you put a full cap if that's the case. Sometimes you can start with half a cap, so it really depends. You do want to mix it into something that they'll drink right away. Okay. One of the key things with things like Miralax is that you have to give it right away. If they take an hour to drink it, it's just not going to be that effective.
Okay. And now can you put that in a baby's formula or breast milk?
You can. You want to make sure that the baby does take it right away.
Sure, yeah.
And so if you want to put it in the formula or breast milk, you may want to just put it in maybe 2 ounces. A little bit. Okay. Make sure that the infant can get it right away.
Got it.
With babies, you don't want to start with a full cap.
Yeah.
Sometimes we just start at a teaspoon or maybe half a cap full. So it's really, with a lot of these things, you give the dose that's necessary to soften their poop.
Awesome. Very good.
Yeah. Okay. Cool. Now, if they're really struggling, though, sometimes you have to use a combination. So this one is mineral oil.
Mineral oil, guys. Yep.
So this is a lubricant laxative. Okay. So what this does is, since it's an oil, you don't want to give it directly. You want to mix it either in baby food or in milk. Sure. Again, in a small amount, so that you know that they consume all of it at one time. Okay. And with infants, about 2.5 mLs will work. Okay. You only want to give this once a day, maybe at most 5 days. Okay. But once you relieve the poop, the hard ball, then hopefully you've opened the floodgates and more stool will come out. Yeah, and that's what this is. It's really just, it's like a WD-40.
Hits the wall right down.
Exactly. Okay. So it just makes it, make that hard poop easily come out.
Excellent.
There is another one called Senna, which you can either find in a little chocolate or liquid. And so that one is a stimulant. Okay. It's a gentle stimulant. It just helps contract.
Right, sure.
So when we think about how we treat constipation, the first one is you want to soften it. Okay. The second is you may need a little bit of help with a stimulant, such as Senna. Yeah. And then you can lubricate it with mineral oil.
Got it. Okay.
And then once you relieve the really hard stool, then the main part is just keeping it nice and soft.
Yeah.
And so some of these medicines you may have to give every day. Some parents get scared, like, oh, why do I give it every day? Are they going to get hooked on it? And you'll see, you can Google it. Yeah. And some of these will say you don't want your child to be on these medicines for long periods of time.
Sure.
But at the same time, if that's what they need, you just have to give it to them.
Yeah, and I have a lot of patients on Miralax every day, and that's fine.
And they're
it just
fine.
passes right through.
Yes.
Yeah.
Exactly. Now, some people do say, "Oh my gosh, Miralax, it's bad for you." It's the same thing as an antifreeze, and I get that a lot from families, and so they're hesitant to use Miralax. But it's two different compounds.
Correct. Yep.
Ethylene glycol is an antifreeze, and that's toxic.
Yeah.
Whereas polyethylene glycol is a different compound, and that's actually found in a lot of other foods.
Yeah.
Besides Miralax itself, you can find it as other inactive ingredients, is what they'll call it. Absolutely. And so that's not toxic.
Correct.
And so that is one of our go-to, and if kids did have to get admitted because of really bad constipation, we use polyethylene glycol as a clean out anyway.
All night.
Yeah. You remember that.
I remember those days.
It's not fun.
Exactly. No.
And so now, and then the lubricant laxative, that one is my go-to as well. Some babies or some toddlers, it just really depends on what they'll take.
Yeah.
And
Absolutely.
so you just have to work with the moms and the dads and the kids and see what they'll take, and then you go with that.
Perfect. Excellent.
Yeah, and so those are for the littles.
Yeah.
Now with the toddlers, they tend to like chews.
Yeah, absolutely.
And so I always tell parents, like, if you buy something like the chews, you gotta put it up high because you don't want to.
I think it's candy, pretty much. Yeah.
Exactly.
All these Dulcolax kids, soft juice. Yep.
Yeah. So this is just two different flavors. As you can tell, the first one that Dr. Stone held up, it says kids. But again, it's really important that you always read the active ingredients. So in both of these, they're both magnesium hydroxide, and they're both 1,200 milligrams.
Same dose. Yeah.
Same dose.
Yeah.
One is just marketed for kids because it's watermelon.
Advertising.
That's the only thing.
Yeah.
Advertising.
Yes.
Exactly.
All right.
And so as you can tell, 1,200 milligrams is a lot of magnesium. I'm pretty sure if I took something like this, it would be good.
Right.
I might have to call into work the next day.
Yeah.
So I just tell families to just cut it either into thirds or into half.
Nice.
And then just give it every day. Just it's very gentle.
Sure.
It's like taking a vitamin supplement, and you just take it every day. And then once you get a good stool consistency, then that's the dose that you stick with.
Got it.
And then for the older kids or the ones that don't like chews, you can use something that has magnesium in it already.
Okay.
And this one contains magnesium, calcium, zinc, vitamin B3, so you get a lot of extra healthy vitamins.
Sure.
And so if you have to take 3 to get the necessary 400 milligrams of magnesium.
Yeah. Cool. Okay.
So magnesium I like just because it is one of those medications or supplements that people can take, and it's more natural.
Sure. Very good.
And then, of course, Miralax can be used at any age.
Yep.
X-Lax, which is the Senecot, which is a stimulant, that can be used at any age as well.
Okay.
And then as they get older, if they don't like chew, then there's always the pill form.
Yeah.
And then there's also Docosate, sodium, which is also in pill form. So
Got
you
it.
have it in liquid and pill.
Perfect.
And then there's one big one that I tend to not use called Bisacodyl.
Okay.
It's a really strong stimulant.
Sure. Okay.
That's probably the N1 because a lot of people, if they take it, causes really bad cramping.
Got it. Okay. Especially in kids would not be super comfortable.
They will not be comfortable, and they may be crying all night.
Oh, okay.
And so that's something that,
like
unless it's really bad,
that's
something that you want to avoid.
Okay.
But people can mistakenly take it because when you look in the store, it'll say gentle laxative.
Oh, advertising again.
So it's really important, again, when you use these, they're going to have the same name brand, so just look at the active ingredients so you know, okay, which one do I want? Do I want a softener, a stimulant, or a lubricant? And sometimes when it's really bad, you use all 3, and then you stick with the softener and maybe a stimulant here and there.
Got it. Okay. Excellent. That was a great answer.
I know a lot of stuff, maybe more than you really wanted to know.
That was everything I think I could ever ask about constipation. That was great. All right, next question. What is your advice for the parents of children who are picky eaters? What is the best method for parents to make sure their children are eating a balanced diet?
Oh, so that one is picky eaters, I think, is another big portion of my practice. And so I got this plate because picky eaters tend to be around 2, 3, 4 years old.
Yeah.
And so you want to choose something fun. I got this one on Amazon.
Oh, very cool.
And it's a plate that they really designed for picky eaters.
I love that. Yeah.
And so what you do is you put things that they're familiar with,
Yeah.
things with different consistencies.
Cool.
And at the end, you put something that they're favorite of their pie.
A little treat.
The little treat.
That's cute.
So it's really nice. Yes.
Yeah. Here you go, guys. I don't know if y'all can see this or not.
And they have different versions. They have princesses. They also have one with toys that are geared more toward like blues and reds, and so they have different color schemes.
Yeah.
The nice thing about this is that you just put small pieces, which is nice.
Yeah.
And so the child doesn't feel overwhelmed. So that's one of the biggest parts for picky eaters is you don't want to give them a plate of something they don't want.
Yeah.
Because then they're totally not going to
Exactly.
finish
It's
it,
totally
right?
turned off. Yeah, it's like a next gen sticker chart.
And so this one you just put little pieces on what you want them to learn to eat.
That's cool.
And then they build on it, and then there's
Make
a
a
prize
treat.
at the end.
I like that a lot.
Yeah, so this is a fun
These are my
one.
household.
So this came from my household.
Yeah, there you go. Yeah. The truth is revealed.
And then another one for my household is just making things fun.
Sure.
I think that the fun part about pediatrics is we always get to do fun things.
Absolutely.
And so for little girls, little boys, or you can choose whatever plate they want that they are familiar with, and so you can put things again that maybe a small piece that they don't like, a food that they do like, and just giving them that opportunity.
Absolutely.
One of the big parts about trying to help picky eaters expand their diet and their palate is really trying to use positive reinforcement.
Yeah.
So you don't want to you don't want to punish them. Sometimes you do need a thicker chart. But consistency is always important. Having goals is always important.
Yeah.
Sounds like life.
Yeah,
Anything in life,
absolutely.
right? Consistency and goals.
Yeah.
And if it gets really bad, there are feeding therapists that can work with the kids, nutritionists as well. And then Children's Health does have the feeding program.
Oh, right. Yes, I remember that.
And those are definitely more intense.
Yeah, definitely.
But it varies on like how bad is the feeding problem,
Yeah.
is the picky eating.
Yeah.
Some picky eaters are growing and they're flourishing. They may be slender, but they're fine.
Sure.
They're meeting all their nutritional needs.
Yeah.
And one of the part that I always tell my kids, my older one follows it, my younger one so. But it's like making your plate pretty.
Yeah,
And that's
definitely.
how you can ensure that they're eating a nice wide variety.
Sure.
And so they have fruits and vegetables, which are really colorful.
Yeah,
on the
very.
plate.
Right.
The grains not so much.
Yeah.
The protein not so much. So
Yeah.
the ones that make it healthy and that gives them extra vitamins are really the fruits and the vegetables.
Got it. The more colorful ones.
The more colorful the plate,
Sure.
the healthier it is.
There you go.
Usually, as long as it's not
typically.
candy
Yeah, exactly.
on there.
There's some Starburst in there. Make it really colorful.
Yeah, it's a reward.
That's right, yeah.
Now, one of the things that has come about that a lot of parents ask me is about baby-led weaning.
Sure. Yeah.
At first, I didn't really know about it. I read a little bit more. I think the American Academy of Pediatrics still has yet to make their own statement.
Yeah.
One of the biggest parts with baby-led weaning is basically the concept is that you let the child choose.
Yeah.
But it's different consistencies that you introduce. You want to introduce things that they can touch but are mushy.
Yeah.
But you have to be careful to make sure you don't introduce food that are choking hazards.
Sure. Absolutely.
So I think that's one of the biggest parts is
Yeah.
some of these could be choking hazards.
Right.
The second part is whether they'll meet their nutritional needs
Sure.
because they're the ones choosing and you're not spoon feeding
exactly.
them.
Yeah.
But I think to try to help prevent a picky eater is a bigger deal than dealing with a picky eater.
Preventing the problem.
Exactly.
Yeah.
So you want to prevent the problem before it happens
Yep.
because once they become 4 to 9, those kids who are picky tend to be picky the
Yeah.
rest of their life.
Sure.
It probably doesn't improve until they're adults.
Yeah.
So if you can prevent the picky eating habits, then that's probably better for them.
Yeah.
One of the things is really just allowing them to be messy.
Sure.
My mom, she's not watching this, helped me a lot.
That's right.
But she definitely would, every time she would help me, when she would feed my child, she would wipe every little thing.
Yeah.
And, you know, and at first I was like, oh, that's fine. That's how you want it. You want to keep
Yeah.
your baby nice and clean. But I don't think that's the right way to go.
Yeah.
Having being a mom of a
Yeah.
picky eater.
Sure.
You just want them to be messy, let them explore, trying to make sure that their mealtime is at your mealtime.
Okay.
Also making sure that what you're preparing is also what they're eating, so
Yeah.
not making a special meal
Sure.
for them. And then just having them try something that they don't like multiple times.
Okay.
So that their taste buds can get used to it.
Yeah.
But then balancing that out with not punishing them, not getting mad at them, which can be really hard as
It's
a
difficult.
parent.
Yes.
Yeah.
I understand that.
So a lot of these things I feel
Yeah.
like I've learned to manage mainly because I live with these issues.
Yes, absolutely. That is the best teacher. For sure.
Exactly. Having your own children have these problems.
Yeah. Excellent. Great answer. So, next question. Can you talk about the evidence behind the earlier introduction of highly allergenic foods such as peanut butter and eggs in infants?
Yeah, so this comes in a timely manner. I was at a dinner last Sunday, and one of the soon-to-be moms has really bad peanut allergy.
Okay.
And then so she was asking us,
Yeah.
being a group of pediatric GI
Yeah,
doctors,
that's a good
she's like, what?
cohort to
Yeah,
ask.
exactly. She's like,
Yeah.
what should I do about introducing peanuts?
Yeah.
And so the way, so there was a study called LEAP in 2015. So it's called Learning Early Peanut Allergy Introduction. But basically, what you're trying to do is with the LEAP study, what they looked at was in the patients who were introduced peanut earlier,
Okay.
then they had less likelihood of having peanut allergy later on.
Interesting. Okay.
But from this study, what the AAP, American Academy of Pediatrics, did was they did stratify whether if you have severe allergy or severe risk, so
Okay.
those babies with severe eczema,
Sure.
the ones who already have an egg allergy.
Yeah.
So those babies do need some sort of testing initially, either a blood test
Interesting.
or skin prick
Okay.
skin prick testing. So
Okay.
the pediatrician, you guys can do the blood testing,
Yeah.
but the skin prick testing is usually done by the allergist.
Yeah, sure.
Exactly.
Yeah.
But it depends on what the results are,
Okay.
and if they're both negative, they say that you can introduce, but usually introduce also in the office.
Oh, interesting.
But
Okay.
but if they're positive, then those it's probably best to go ahead and refer to a food allergist.
Interesting.
So
Okay.
it depends on
Yeah.
what the results are
Yeah, the
from that
severity of
test
the
and the
allergy.
severity.
Okay, that's
Exactly.
really interesting.
But to be honest with you, if I had a child who had all of those things
Yeah.
and I had a food allergy myself, a peanut allergy,
Yeah.
I'd probably just go ahead and see the food allergist.
Yeah, I agree.
You know,
Yeah, agreed.
and a great one is Dr. Bird.
Okay.
If you know him.
Yeah, I know the name.
Yeah,
I don't know if I've ever met him.
Dr.
Or-
Drew Bird. Yeah, he's great.
Yeah.
So I had to actually phone a friend.
Okay. All right.
To answer that question
Yeah.
because he and I work closely together with
Nice.
different types of food allergies.
Very cool.
And especially like eosinophilic
Yeah, of
esophagitis,
course. Yeah.
or even the ones who have like milk protein allergy
Yeah.
who don't outgrow it.
Yeah, classic.
He tends to be my phone a friend.
Nice.
And I'm like, hey, Dr. Bird.
All right.
What should I
Shout out
do?
to Dr. Bird.
Yes, yeah. And one of the things he did point out is with egg allergy, those tend to occur before 4 months of age. So those babies you'll pick up. But they do say that you don't want to introduce raw eggs, obviously.
Of course.
So if your baby is trying anything that has egg in it, it should be cooked.
Yeah.
And then when it comes to peanut allergy, usually if you do develop a peanut allergy, it occurs after 6 months of age.
After 6 months. Okay, interesting.
And then if you do want to introduce peanut, so if you're in that mild to moderate or no allergy risk at all, those you can try introducing at home.
Okay.
Well, of course, if you have no risk, you can go have at it.
Sure.
The mild to moderate you can introduce at home, but anytime you do introduce something at home, you want to have Benadryl on hand already because this is an IgE mediated, and you can have full hives, anaphylactic shock, you know, all of that bad stuff that you hear about allergy. Exactly, things that you don't want to happen at home.
Absolutely.
And so, like they have, Trader Joe's has a bunch of different types of peanut containing food that babies can eat.
Oh, interesting.
Like there's this one called Bombas. So
have
you seen those?
I know Bombas. Yeah.
I have a patient that's really obsessed with them.
Yeah, a lot of my parents will say, "Oh yeah, we got Bombas." Yeah.
So that one's a good one.
Yeah.
There's also like powder that you can introduce, like peanut
mix
powder
in.
that you can mix
Sure.
in.
Cool.
But having like true peanut butter, that one I think tends to be a harder consistency for the baby, or for the infants, just because it's still very sticky.
Yeah, that makes sense.
Yeah.
Okay, cool. Awesome. All right, moving on. We are on our next question. What is the cause of celiac disease? What are signs and symptoms parents should be monitoring in their children?
Yeah, another good question. I just diagnosed 2 kids with celiac disease this week.
Okay.
It's I feel like it's picking up, but maybe it's my view is skewed. Always.
Sure.
Of course, I'm going to see the ones who have issues.
Yeah.
And so celiac disease, you can have a genetic predisposition. It's the DQ2, DQ8. If you have one of those genetic types, then some of those people would then go on to develop celiac.
Got it.
Now, just because you have that genetic variant doesn't mean you'll have celiac, but
if you don't have it, then you have a very strong chance of not having it.
Exactly.
Yeah.
Yes.
Okay.
That's what's nice about that genetic testing. Even though we don't do it, I know 23andMe, I think, will pick up, you know.
Halfway right.
Yeah, you can see that on the 23andMe. And so if you, like you said, if you're negative for the gene, then the likelihood of developing is really low. But if you have the gene, then you can be at risk for it.
Yeah.
But you may not necessarily get it.
Yeah.
And so in the ones who do have that genetic predisposition, once they're exposed to enough gluten, so around, I would say after 6 months, so 9 months and on up, when they're getting gluten in their diet, their body basically sees it as a foreign material, like a virus or something. And so then it makes the body create antibodies.
I see.
And all of the action is taking place right there at the small intestine.
Sure.
Where the villi are, and the enterocytes.
Yeah.
And so what occurs then is when you have these antibodies there, then it's attacking that area.
Sure.
But there's no virus except there's gluten.
The body.
So it's basically attacking itself.
Yeah, definitely.
And so then it gets to the point that the villi, instead of nice long finger-like projections, they start getting smaller and smaller. And then that limits the amount of nutrient that they're able to absorb.
Sure.
So fat-soluble vitamins like vitamin D, vitamin A, E, and K, those are the ones that get compromised.
I see.
But because the disaccharidase, which are the sugar enzymes, are also at the tip, sometimes these kids can also have problems with absorbing sugar.
Oh, interesting.
So lactase would be an issue. Not that it's permanent, because then once you remove the gluten, then they'll grow back, but it takes a while.
Okay.
And then, you know, if there was any disaccharidase deficiencies like lactase or sucrase, then those tend to resolve as well. Because then everything gets restored.
Yeah.
The signs and symptoms, so in the past, I'm sure in the textbooks, like we get taught that these kids will come in with bloating, they're very emaciated and cachectic, so their extremities are really thin, there's not much muscle, they're miserable. But nowadays, because it's always on everybody's mind, especially that gluten-free is almost a diet trend.
Right,
you know, people wonder, they're like, oh, am I gluten intolerant, do I have celiac? And so everybody's thinking about it, and so these patients get picked up pretty quickly.
Sure. Yeah.
And then the test that we have, which is a serum IgA and tissue transglutaminase IgA, the sensitivity and specificity is high, like high 90s.
Oh, nice. Okay.
Now, one of the things that the pediatricians need to remember is the fact that if the child is under 2, then you do need to send, it's called deaminated gliadin, IgG, and the serum IgG as well.
Yeah, right.
And so though that's more sensitive in picking up these kids.
Got it.
Because that tissue transglutaminase IgA may still be normal, but then the deaminated gliadin IgG may be positive.
Got it.
And that'll be your first clue.
Very good.
These kids can be iron deficient. I've seen kids where they've just lost patches of hair.
Interesting.
Rashes, just weird, unexplainable rashes. And the kids who have type 1 diabetes, they do get screened for it. Kids who have thyroid problems.
Yeah, all the autoimmune.
All
processes.
the autoimmune.
Yeah.
So if your child has one autoimmune and they're having any type of GI issues, even constipation. Or just bloating.
Sure.
Diarrhea, interestingly, because we catch it so quickly, has not been a prominent
That's
symptom.
really interesting, because that's what you get taught in medical school and residency. If you're not having diarrhea, then you probably don't have celiac disease, but that's changing. The mantra is changing.
Definitely changing. Even as a fellow, I wrote up a case and presented it in our conference, and the title was Celiac Disease, a Snake in the Grass.
Yeah, nice.
And I got that title from my mentor,
Dr.
Anderson.
It. Yeah.
Like, just like a snake in the grass.
Yeah.
Title of the poster.
I love it.
You know?
Always like the creative posters.
Yes, yeah. And basically the main point of that one was that it kind of just snuck up on us. We had this little girl, she was 4 or 5. The big problem with that her belly was distended and she really had bad behavior. I mean, she was a mean little girl. And you're like, what? She was so cute, but she was just cranky and just very unhappy.
Okay.
And so we set the testing off, did an endoscopy to confirm the diagnosis.
Sure.
And as soon as she got on a gluten-free diet, I saw her 3 months later and she was a completely different girl.
That is wild.
It was wild. And
yeah.
I think just the stark difference of her personality when I first met her compared to when I followed her up in clinic and subsequently after that, completely different girl.
Man, that's amazing.
Yes. And the other part is that they don't grow.
Sure.
Because they're not absorbing the nutrients that they need. That's always a red flag is when a patient comes in, their belly is big, they're just not growing the way they should, either in height or in weight or both.
Okay.
Definitely celiac disease should be tested for.
Interesting.
Sometimes in the teens, they just come in with vomiting, like random episodes of vomiting, random episodes of stomach pain, almost like that irritable bowel syndrome. And so all the kids that come to me, I mean, my other colleagues may not do this, but when I see a kid who has IBS type symptoms or the irritable bowel type symptoms, I go ahead and just test them, whether it's constipation, diarrhea, on and off stomach pain, those kind of, they just by themselves as a test.
Celiac panel. Nice.
Right.
Cool.
Recently I was just following a girl whose weight was on the higher side with elevation in her liver test.
Okay.
But her mom kept saying her belly is just bloated and I don't know why. And so you always have to listen to the mom.
Of course.
I think you know that part
right.
too.
Moms
you know?
know best, right?
Moms know best. They know their kids.
That's right.
And so so she was like, there's something wrong.
Yeah.
So we sent off the celiac test and sure enough, her test came back and it was positive. And again, it was different because the issue she was having was more constipation and elevation in liver test, and her weight was on the higher side.
Huh. Yeah.
And so people don't really expect that because, again, you expect somebody with diarrhea and losing weight and not growing well. But it just really depends on the kind of foods that people eat.
Sure.
Nowadays, we consume so many high calorie type food that you can pretty much
overcome
overnurture
the caloric deficit.
Yes.
Interesting.
Easily.
Yeah.
You know.
Very cool.
So I think if you ever have a gestalt or a high index of suspicion that you should test for celiac, just send it.
Yeah.
And it's easy enough to send. And, you know, sometimes what I've noticed too is one of the parents end up having celiac.
Oh, really?
Yes.
I guess that makes sense if it's a haplotype based disease, at least puts you at risk, then most likely the parent has the same haplotype, which puts them at the same risk.
Yes, yeah. And
Interesting.
so if you're a first degree relative, you have a 1 in 10 chance of having celiac.
Really? Wow, that's pretty high.
It does
10%.
go up. Yeah. It goes up pretty high.
Yeah.
Down syndrome is another one with high risk.
Yeah.
And then, like you said earlier, all the autoimmune diseases are higher risk, and type 1 diabetes.
Yep,
you know?
absolutely. Very good. Okay. Big topic, next one. Can you discuss infantile reflux and differentiate between physiologic reflux and gastroesophageal reflux disease?
Yeah, another good question. I think a bulk of my baby patients have this problem. You know, a lot of times when patients present with reflux, it's more that they're fussy.
Yeah, definitely.
And then it's up to us to say, well, what does fussy mean, or like what's happening in your household that is making the baby not that you're doing something that's making the baby fussy, but what is happening that's manifesting as fussiness. You know, is it that the baby's arching their back? Are they trying to nurse and nurse pulling off, like trying, hungry, they're hungry, but then they can't eat. And then you lay them down after you fed them and they're just like really fussy and super uncomfortable, and they may look fine. And then of course they spit up, they'll vomit. And so these babies, that's where you say, okay, it's beyond just the physiologic reflux. You're now going into gastroesophageal reflux disease.
Sure.
So you know that all babies reflux.
Yeah, of course. Always have this talk.
Exactly.
Exactly.
They're like always, right?
Yeah.
And so in that case, it's really just the anatomy of the infant.
Of course.
Right? Their tone, just like their tone is low in their whole body, their tone inside their GI tract is going to be low. That lower esophageal, gastroesophageal sphincter or LES, or that part is really lax. And so whenever the stomach contracts and propulses to try to push the food forward or the formula, then some is going to come
retrograde.
back.
Sure.
So it ends up retrograding sometimes all the way up. So when that happens, then the babies can spit up or
come through their nose.
Come out of the mouth. It looks like really scary. But that, if the baby is growing fine, is not unhappy, and I always have a conversation with a parent like, well, there's not really any bad red flags here. This will get better. Do you want to start medication? Do you want to not?
Yeah.
But the ones who are fussy, who are not gaining weight well, those, we just go ahead and start on an acid suppression medication. And I brought some.
Okay,
here.
all right.
I have some. Okay.
Very good.
So one of the first ones is Pepsid.
Yep.
You know, this comes in liquid form for babies, famotidine.
Now, is there famotidine liquid over the counter? Because I always have to send in a script.
No.
Okay, that's what I thought. I just wanted to make sure I had not just missed it at the grocery store.
Yes.
Okay.
And thankfully, insurance is still covering famotidine for the infants.
Right.
What they're not covering as much are things like lansoprazole, omeprazole, so the proton pump inhibitors.
Right.
These tend to work longer and what we call they're stronger.
Yeah.
And the way you administer this is going to be before they eat, let the body absorb it because they're prodrugs, meaning that they have to be absorbed, and then once you eat, they get activated, and then they work.
Right.
And usually at the time that you start eating, your pH in your stomach actually goes up.
Sure.
But then your stomach then starts making more acid to break the food down, and so then it brings the pH down, so you become more acidic.
Right.
Well, when you take these medications, then the amount of acid that your stomach can actually make is lower.
Got it.
And so it's not as acidic. So if it comes up, it's less acidic, or
burning.
maybe not even.
Right. Yeah.
Right.
Very good.
And so it's not burning. It's not causing the symptoms.
Yeah.
So this one is lansoprazole, the strawberry one.
Yeah.
Have you used these?
Oh yeah,
before?
because I like it because you can actually get it over the counter, and so I usually I'll put them on famotidine for a month. I'll see how things are going. If things are going great, I'll transition to this and see how they do, and then if we'll try to take it off later. But yeah, so that's the usual step, and like you said, insurance doesn't cover it. But it's nice, but you can still get the disintegrating tablets for the babies that you can mix in breast milk or formula or whatever.
Yes, exactly. Because I know in the past, like what's happened before is when insurance doesn't cover it, then sometimes we'll use the capsule and then they break it open. But that's a lot. And whether they even get any of it is hard to say. And thankfully, there's all different versions. They have lansoprazole. All different brands. Yeah. So you can even get it on Amazon, Walgreens, CVS, Good Sense, Kroger had their own. Yeah. And then there's also omeprazole.
Oh, I didn't know you could get omeprazole.
Yeah, so omeprazole now is there. So you have two options.
Yeah. Excellent.
Because sometimes they don't react well to one, and then you choose another one.
Yeah, definitely.
Nexium, though, is still a packet, and that one can be pretty expensive.
Yeah, I've seen that as well.
I think a lot of these can be pretty expensive.
Yeah, I had this exact conversation today, actually.
Oh, yeah?
Because there was some confusion about sending in a script versus getting over the counter, and the script was $120 a pop, and these are like $10. I was like, yeah,
yes.
exactly.
Yeah, exactly. And you know, and with some of them, like this one is a 14-day tablet, but a lot of them are for you too. Yeah. And you can get it for $15 to $25 versus $100. Sometimes some parents have told me $300.
That is insane.
It's crazy. I'm like, please tell me before you buy it. Yeah. Don't ever pay anything over $25.
Exactly.
Now there are in a few cases where the parents prefer that it's already in liquid form.
Yeah.
And in those cases, then you just bite the bullet and you send the script in. And so, you know, the other part is our society, the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. Yeah. So that we are trying to make sure that when we evaluate babies for infantile reflux, that we're also looking for other causes. Sure. Meaning, is it rather, instead of infantile reflux, are we actually dealing with more dysphagia or aspiration? And so when we talk to the moms, we try to get into more detail about how are they receiving the food. Is it, if they're breastfeeding, is it that the letdown is so fast and then the baby's choking? Or no, the letdown is okay, or it's mid-feed and they're still choking. Or do they also have problems with noisy breathing and some laryngomalacia? And so these are factors that then say, okay, you probably need to evaluate further.
Yeah, interesting.
You know, but with infantile reflux in itself, usually they hate this line, but it gets worse before it gets better.
Yeah, correct.
And so at the time that they're starting to learn to push up and they're trying to build their truncal control because there's just more pressure, the reflux will actually get worse. So
Yeah.
between 4 and 6 months, that's the time where I'll have parents call me and they're like, things are getting worse. They're vomiting more. They're more fussy.
Right.
We're in a bad spot.
Yeah.
And sometimes what I'll do is add a second prescription medication just during that time frame, or even change formula.
Sure.
Just anything to try to help bridge that gap. And then by 6 months, then they're upright, their tone is better, their truncal tone is much better, they have better head control. And so 6 months, you can start seeing things get better, and by 8, 9 months, then I start weaning the medicine off.
Nice.
Is that what you usually do?
Pretty typical. Yeah, that's the typical pattern. Like you said, do see it get worse between 4 and 6 months. And then once you, and especially when you start eating more solids too, and obviously you're having less liquid able to come up, and so the solid keeps things down. And like you said, you're more upright, and so typically things get better the second half of the first year than they were in the first half.
How often do you use the Infamil AR? Have you found that?
I don't use it very often. I'll be honest. Because I had a discussion with the parents of, talking between physiologic reflux and GERD, gastroesophageal reflux disease. I was like, typically, I can't say, hey, I can't give you medication that says, hey, tone, get tighter and hold stuff down.
Right.
I can say, hey, stomach, become less acidic, and that way when you do have reflux, it is less symptomatic.
Right.
So I usually go, and so like, as you know, people used to like rice cereal and like all these things in it. I've gone away from that. I usually just treat it with acid blockers, and then things seem to get better. I do have I know some people that do the anti-reflux formulas, and I think they have good success too. But I think we just have gone different routes.
Right. Yeah. And I think it depends, right? It depends on the infant that you're dealing with, what the parents are comfortable with, because some parents don't want medication and they'd rather go that way. And, like you were mentioning, thickeners can be used, like rice cereal. And the concept behind that is exactly what you said, is you're just keeping it down. It's not like you're decreasing the acid.
Right.
And in babies who tend to have problems with choking as well, thickening their formulas tend to be you're hitting two birds with one stone in that. But like you said, I mean, for both of my girls, of course, they had really bad reflux and were super fussy.
Only appropriate for a GI physician.
Exactly. And I swear, like, no, the second one won't have it. Because they just won't.
That's right. Just will it into existence.
But she still did. And I mean, but it does make a night and day difference of when your infant is not fussy, you're less stressed. You can lay them down, and everybody can sleep.
Absolutely.
And so it's really a huge factor in the family. And so when you say, oh, we'll just bite the bullet and start the medicine, sometimes you really just have to do it for everybody's sake.
Everybody's mental health.
For everyone's mental health.
I'll say there is, in medical school and in residency, it wasn't that anti-acid in infants was like, no, you don't do it, but it was more of like, hey, you should at least think about other options. And then when I got into private practice, I was like, and of course, this is all anecdotal, but the difference it makes, and especially in families' lives, parents will come in with horrendously fussy babies. I'll see them back in a month or so, and they're like, our lives are totally different.
Right.
It makes a huge difference in everyone's lives.
Exactly. I know. And that's the same for the NASPGHAN society, is that, they really are pushing to get away from medication and just like start thickening first, assess for other swallowing issues, or change formulas. So that's the other thing that you can do, is you can change from regular intact milk protein to then partially hydrolyzed, and then to elemental.
Exactly.
And sometimes you have to do both. And then thankfully they grow out of it.
Exactly.
That's the nice part.
They're always going to make it. It's just getting them to that finish line.
And the other thing when you do start acid suppression medication is that it takes a while. It's not like a night and day difference. And so that's one of the things I'm sure you explain to families too, is that you'll just slightly notice that things are less stressful. That you're laying down instead of sleeping upright all night long like this.
Definitely.
And you're not like waiting for the other person to come home.
Exactly. That's right. Your life gets a lot better in a lot of ways.
Exactly. So I think it just depends on the parent, the symptoms of the baby, and what they respond to the best.
That's great. Very good. All right, so we will move on to our last question of the night. How should parents take care of their children when they have run-of-the-mill diarrhea? is the brat diet or any other bland food diet still recommended?
Yeah, so this is another great question, especially that we're in the summertime.
Correct.
You
yes,
know?
a lot of pool-associated diarrhea.
Yes, a lot of viruses,
Yes,
a lot of open parasites going around, even bacteria.
Right.
And so, as you know, with the brat diet, that the bananas, rice, applesauce, and toast, a lot of nowadays, like, we've gone away from that, and the recommendation is you just feed through.
Right.
Of course, if the diarrhea is bad, you want to make sure you do the oral hydration therapy. So that includes like Pediatric. There's also infantile. Juice and broth. Those don't really count, but if you need to give it to them, you can.
Stay hydrated. To
exactly.
Yeah.
And then there's the rule of for infants. 30 mLs per hour or 30 cc's, which is 1 ounce per hour. For a little bit older, you want to go to 60 mLs per hour.
Sure.
And then for the older kid, 90 mLs per hour. So just different stages on how much fluid they need. And this is really a way to try to keep them out of the emergency room and then just keep them hydrated.
Right.
If they're also having vomiting with the diarrhea, you can use Zofran.
Sure.
The nice thing about Zofran is it does also slow the motility down.
Nice. Yeah. So you get 2 birds with 1 stone.
2 birds with 1 stone with that, exactly. So it's like, okay, it helps with not having them throw up.
Right.
And within 30 minutes, you can try to do oral hydration again.
There you go.
And then it does slow the gut motility, so hopefully the diarrhea slows down.
Definitely.
But we don't recommend using things like Imodium or anti-diarrheal because if it is a serious infection, then that can make things
Holding
worse.
all the bad stuff in.
Exactly. And then that colon can just get really big.
Yeah, infected and all those things. Yeah.
Yes, and then you have a bigger problem than just the diarrhea.
Yep.
And again, so you and I talked about this, that this is not full medical advice. This is based on our experience. So my personal experience is I do like using kefir or kefir, however you want to pronounce it, but it's Kefir.
Okay.
What's nice about that is it has all 3 good bacterias. So it's got lactobacillus, which is typically in all the other ones, like Culturelle. But it also has bifidobacterium. Some of them have the Saccharomyces.
Sure.
And so it's a nice wide variety of probiotics. And so that tends to help the gut microbiome a little bit better than just lactobacillus alone. So that's what I prefer. I usually just say 1 to 2 ounces.
Sure.
And the babies, it's harder because I don't know exactly how much they need, but also that it's a dairy-containing product, so you have to be careful. There is a brand called BioGaia, and they have infant drops. On Amazon, there's so many other probiotics too. So I am a fan of probiotics because it just helps restore the gut microbiome. So that's the bacteria, everything that's supposed to be in there, it helps restore, hopefully. And then once you're making sure that they're hydrated, you just feed through, but you definitely, I think this is obvious, people know you don't want to give them fried foods. No French fries. Even though that some may want to eat that, you know. And I think that's probably where the brat diet comes in, is that it's more bread, toast, crackers. It's what people want to eat when they're feeling sick. You know. But definitely oral hydration therapy is one of the mainstays of treatment.
Awesome.
Yeah.
Very good. All right, everybody. So that wraps up tonight. Thank you to our guest, Dr. Charina Ramirez, for joining us and answering all of our questions. It looks like we probably have a few write-ins. I'll look back over them and see if we have anything I can answer later. But did we already discuss constipation? Yes, we did discuss constipation as the very first question we talked about. So you can go back. I'm going to be posting this video not only on our Instagram profile, but on our YouTube channel as well. And again, thank you to Dr. Ramirez, my former mentor in residency, and a pediatric GI physician at Children's who can see pediatric patients if y'all are interested, if bringing y'all's kids to her. And thank you again, everyone, for joining us. Probably going to try and do another one next month. My wife is due in September, which I don't even know. You may not do that. Yes. So, well, I'll come up with a schedule here later. It may be a little in flux with the new baby.
Hopefully no constipation.
That's right.
No
Hopefully
reflux.
no constipation issues for us. But I'll post that whenever I know. Thanks, guys, again. We'll see you next time.
Okay, bye, y'all.